Hello, everyone. Today, we'd be discussing a few topics from the unit patient practitioner relationships. Now, this unit, patient practitioner relationships, comes under the heading of health psychology. This topic that you see in front of you, that is patient and practitioner diagnosis and style, this is the second section from that particular unit. As I keep on telling you, every unit is divided into three sections, and each section is divided into different bullets. Now, these are the bullets that I typically refer to, and this is the section that we're talking about. Now, taking this ahead, about this particular section, we have a case study that is a part of this section as well. As you all should be aware by now, that in this current paper pattern, in this new syllabus, through this new syllabus, each unit would comprise of a key study. Now, this is the key study that is a part of the unit patient practitioner relationship. However, we would not be covering this part today. What we'd be doing today is practitioner diagnosis that focuses on making a diagnosis. When we talk about making a diagnosis, we discuss disclosure of information. We talk about false positive and false negative diagnosis, and we speak about presenting a diagnosis along with coping with the diagnosis as well. Now, taking this ahead, when we talk about a consultation, as we talk about a consultation, I'm sure you'd all agree that there are three factors, there are three different phases that a typical consultation goes through. Number one, making a diagnosis. It's pretty essential that the practitioner or the doctor makes a correct diagnosis. And there are several factors that affect that correctness of a diagnosis, such as the extent to which the information that is provided to the practitioner. There would be many patients who would not be very comfortable sharing what they're actually going through. Many individuals, many patients, they experience certain embarrassing symptoms which they might show reluctance towards while discussing them with the practitioner. Now, number one, as I said, making a diagnosis. Number two, presentation of the diagnosis is important. Number three, coping with the diagnosis. Without any further ado, let's begin. Like I said, making for a practitioner to be able to make a diagnosis, the practitioner requires the patient to be honest. Now, disclosure of information over here plays a very important role. If the practitioner is not disclosing enough of information, this might eventually result in an incorrect diagnosis. At the same time, uh, if a patient is exaggerating his or her symptoms, that might again result in an incorrect diagnosis. At the same time, if a particular patient is showing reluctance towards sharing something that he or she should not have, this could result in an incorrect diagnosis as well. Now, when we speak about disclosure of information, I'm sure you'd all agree communication plays a very important role here. Now, this for this communication part, as we discussed this in the earlier section, in the section before this one as well, if be it verbal communication or even non-verbal communication, this communication has a very crucial role to play when it comes to the consultation. Now, taking this ahead, before we proceed, let me remind you all, as I said, we have certain references, certain researchers that are referred to as example studies in our syllabus, right? The researchers that are referred to as example studies in our syllabus, they are the ones that the examiner could possibly test you on with while naming them, right? In your CIs, there's a possibility you might come across a question related to any example study. However, besides the key study, besides the example study, there are several other references that are a part of our book, that are a part of, I mean, that what I believe is a student should know of. Nonetheless, bear this thing in mind, because those references, they're not specified in the syllabus, you might not end, or you would not end up being questioned on them directly. Nonetheless, a frequently asked question is, do we study them? Of course, you study them. Another frequently asked question is, how do we put them to use? You put them to use while you're writing your evaluations. You put them to use while you're writing, answering descriptive questions. So these extra references, I've tried marking them in green over here, right? I think it would be better to refer to them as reference studies, right? So we have key studies and then we have example studies. And the third category that I'm referring to over here is reference studies. Now, let's take this ahead. According to Sarafino in 2006 came up with a couple of points. According to Sarafino, patients might encounter challenges in accurately revealing information. Now, there are certain instances when the patient isn't really comfortable or isn't really able to, rather, when there are certain situations, there are certain instances when the patient isn't really able to accurately reveal information. Now, this accuracy over here holds a lot of significance. Now, what sort of instances might they be? Number one, if the patient ends up being angry, or if the patient loses it, or if the patient is critical towards the doctor, he or she might not be able to accurately reveal information. One. Number two, if the practitioner or the doctor asks any particular question and the patient ignores it, that again might lead to incorrect, or that might again lead to an incorrect diagnosis. Number three, if the patient insists on getting medication or getting tests done, which the doctor doesn't really believe the patient needs to, which again could lead to uh, which again could lead to a problem, and eventually consequently which would result in an incorrect diagnosis. Number four, if the patient wants to be given a certificate for an illness that they do not have. Or number five, if the patient makes inappropriate remarks towards a doctor. Now, these factors, according to Sarafino, these could all result in these could all result in the patient not being able to disclose information in an honest manner, which would eventually, as a consequence, affect the diagnosis. Now, number one, we spoke about this study that was conducted by Sarafino. We spoke about a couple of points that Sarafino came up with. Number two, let's move on and speak about the study that was conducted by Robinson and West. Now, this study by Robinson and West, this is again a reference study. Now, I'd rather mark this as green. This was mistakenly marked as yellow, but as we all see, we do not have Robinson and West specified over here anywhere. So yeah, this study by Robinson and West is again an example of a reference study. About this study that was conducted by Robinson and West in the year 1992, what was this study about? Now, Robinson and West, they wanted to figure out, they actually wanted to make a comparison. Robinson and West, they actually wanted to make a comparison. They wanted to figure out if a patient would be more comfortable disclosing information in front of a computer, right? Being interviewed by a computer, or if a patient would be more comfortable disclosing information on a questionnaire. And the third option, if a patient would be more comfortable disclosing information in front of the doctor face to face. So this is the relevance of, or rather say the significance of, a comparison over here is important, is more important when you talk about illnesses that have symptoms that are embarrassing, that are of an embarrassing nature. So to begin with, the study that was conducted by Robinson and West. In this study, they wanted to find out whether computerization leads to greater disclosure from respondents when information is being sought on a highly personal topic. Now, this study, my dear, was conducted in a genitourinary clinic, right? So a GU clinic or a genitourinary clinic. And I'm sure you all do understand that symptoms that patients might be experiencing who would visit a genitourinary clinic might not be the symptoms that they'd want to openly disclose with, right? And that includes a doctor as well. Now, it consisted of a comparison of the data collected by the computer interview with the paper questionnaire in a genitourinary clinic. Both of these were also compared with the physician's records of the same patient. So we're talking about three different factors over here. Number one, a computer interview. Number two, a paper questionnaire. And number three, the physician, that is the doctor. So one, two, and three. This is what we're actually referring to. If we have a look at the sample for this particular research, the participants were 33 male and 36 female patients of a genitourinary clinic in Northern England. Their ages range from 15 to 49 with a mean age of 27 years. Owing to the withdrawal of some participants and some having issues with the computers, there were 37 participants in the computer group and 32 in the paper questionnaire group. Now, a question that arises at this point is, do we need to learn all of this? No, you don't need to. Had this been an example study, had this been an example study, that is, had this study been specified in the syllabus, it would have been important for you to know all the details regarding this. However, since this is not an example study, I'm referring to this as a reference study, you don't need to get into all of these nitty-gritty details. Now, on arrival at the clinic, okay, now another point, if we do not need to know details, why is it that we have them over here? We have them over here so that you all have a better understanding of this particular study. So yeah, on arrival, I'll just quickly brush through this so that you all understand what this study is about and what its significance is like being present in this particular part of the syllabus. So on arrival at the clinic, patients were randomly allocated to either the computer condition or the paper questionnaire condition. Patients were then asked to complete their case histories either through a computer questionnaire, on a paper questionnaire, through a computer questionnaire or a paper questionnaire, and return to the waiting room. Following this, each patient had a medical examination with the doctor, which included a physical examination as well. Now, the data collected from the questionnaires was compared with the patient's medical notes from the doctor's interview. Three key elements were compared here. Number one, the number of symptoms the patient reported. Number two, the number of reported previous attendances at a genitourinary clinic. Number three, the number of sexual partners the patient had had in the last 12 weeks. Now, the results of the study showed that people were prepared to reveal significantly more symptoms to the computer than they would put on paper or tell the doctor. Also, they made more disclosure about previous attendances to the computer than to the doctor. Now, this is what needs to be kept in mind related to this study. This part, I'll just highlight this entire thing for you so that you know what exactly needs to be catered to. Now, I'm sure you all would agree if you talk about if you talk about the information that is provided on a paper, or if you talk about information that is provided by the patient on a computer, you do realize if you're providing information on a paper, that paper could get from one person to another to another to another. So is the case with the computer. The amount of information that you've shared on a computer doesn't really, I mean, what sort of surety or guarantee do you have, or certainty do you have that that information that you've provided through a computer would not get to someone you wouldn't want it to get to? Like, on the other hand, if you speak about a practitioner, or if you speak about a doctor, the likelihood of the doctor not revealing that information with any third person is always greater. Nonetheless, humans being humans, patients might not have felt very comfortable, or rather say the fear of being judged might have led them to not provide enough of accurate information to the doctor, and instead be revealing more with the to the computer or the questionnaire. So this result seems a little strange since the information you give to the doctor is personal and private. But when you are responding to a computer, you have no idea how many people have access to the different information about our health depending on who asks us about it. So this study that was conducted by Robinson and West in the year 1992, what is this study about? The study was about a comparison to see if patients are more open with a doctor as compared to a paper questionnaire or a computer interview. Now, taking this ahead, now, these were we just spoke about Sarafino. We spoke about Sarafino. We spoke about the factors that lead to incorrect information being revealed to the practitioner. Number two, we spoke about the study that was conducted by Robinson and West, and this study had to do with the extent to which patients showed reluctant towards sharing information with the doctor, especially when the information or the symptoms that they're experiencing are of a personal or an embarrassing nature. Taking this ahead, if we speak about if we speak about the doctors are human beings too, and doctors could make mistakes as well, especially in cases where the patient isn't really providing correct information, or the patient is maybe exaggerating or minimizing or undermining any experiences or any symptoms that he or she may be experiencing. So the possibility of the doctors making errors. There are two different categories that we'd put this under. We'd refer to them as type 1 errors and type 2 errors. To begin with, when we speak about type 1 error, what exactly is this type 1 error? A type 1 error is also referred to as a false positive diagnosis. Now, listen to this one carefully. Many students, I've seen many students get confused between between type 1 and type 2 error. So a false positive diagnosis is referred to as a type 1 error. Now, what is a false positive diagnosis? This is when a doctor mistakenly thinks a healthy person is sick. So when the doctor thinks you're sick and you're actually not sick, you refer to that as a type 1 error, which is also known as a false positive diagnosis, right? So it is a positive diagnosis, but it is false because it's a mistake. Number two, if we speak about type 2 error, a type 2 error is referred to as a false negative diagnosis. Now, what is a false negative diagnosis? This is when a doctor wrongly or mistakenly believes a sick person is healthy, missing their actual condition. So, if the person is actually sick, but the doctor but the doctor thinks you're totally healthy, you're completely fine, this we refer to as the type 2 error. Now both of these, type 1 error and type 2 error, what happened to this? So yeah, both of these, type 1 error and type 2 error, these are the errors that are made by doctors. And in this context, we're referring to these errors being made by doctors when the patient is not very honest about his or her symptoms. So now, since these errors would have their consequences as well. Let's quickly discuss about the dangers, about the risks of the possible consequences because of type 1 and type 2 error. So, if we speak about type 1 error, if a patient is healthy but wrongly diagnosed with something, what could be the consequences of this? It may not have a very severe consequence. So, you're actually healthy, but you have been diagnosed wrongly, or you're healthy but the doctor has labeled you as being sick. This might not have severe consequences. Nonetheless, this might lead to the patient, or the rather say the potential patient, being given unnecessary medication that he or she did not need, did not require, did not deserve, of course. Now, these medications might as well have their own side effects. These medications might eventually affect the lifestyle of that particular patient. Moreover, if a patient realizes, I mean, imagine the patient was totally fine, he or she was being diagnosed as being sick, and the patient or the potential patient or the pseudo patient started taking medication which had or did not have side effects. But just imagine for a bit when the patient would realize, when the patient would actually figure out that there was actually nothing wrong with the patient, this would lead to a lack of confidence. This would eventually lead to, very rightfully though, this would lead to a lack of confidence in the medical system. This would lead to a lack of confidence in that particular doctor. So moreover, if a patient realizes there's a misdiagnosis, it could erode their confidence in the doctor and the medical system. This might make them avoid seeking medical help again in future when necessary, or make them less likely to follow medical advice in the future, resulting non-adherence to medical advices. Now, non-adherence to medical advices or adherence to medical advices, this is the name of the second chapter, the second unit, that is a part of health psychology, which we'd study in detail. For now, what you need to understand is the word adherence means obeying, the word non-adherence means not obeying. So if a person who was actually healthy was labeled as being sick, and that person figures this out, this might lead to a lack of trust, like I said, in the medical system, which might eventually lead to the person not wanting to seek help if required to. So this was a possible consequence of type 1 error. Moving on, if we speak about the possible consequence of type 2 error, which could be even more dangerous. Now, imagine for a bit that if a patient is sick, and the doctor mistakenly again says that they're healthy, the patient what won't get the patient won't be correctly diagnosed. If the patient won't be correctly diagnosed, the patient's treatment would not begin, and if the patient's treatment does not timely begin, that could eventually lead to that would eventually lead to the illness getting more severe, which eventually which could end up taking the patient's life too. So this can make the symptoms stay the same or get even worse, possibly leading to a more serious illness, hospitalization, or in a worst case scenario, this could result in taking the life of that person. This could result in that patient dying too. So yeah, we spoke about Sarafino, we spoke about Robinson and West. Number three, we spoke about the errors that could be made by the doctors as well. But before that, if you remember, whatever we're discussing over here, all of this comes under the heading of practitioner diagnosis, right? So while discussing practitioner diagnosis, we initially spoke about making a diagnosis. Number two, let's talk about presentation of diagnosis. So one, the practitioner tries to diagnose the doctor tries to diagnose what actually is wrong with you. Number two, once the doctor has diagnosed what is wrong with you, presenting that piece of information to the patient might be a task as well. Now, taking this ahead, when we speak about presentation of information, after making a diagnosis, the healthcare provider, that is a practitioner or doctor, has to share it with the patient. The usual way, or the typical or the conventional way, is by doing it in person or a face to face interaction. But there's evidence today that suggests that this might not be the best or the only way, right? This is certainly not the only way, but this might not even be the best of way if you try gathering some data, which Cook and Culver tried doing in 2016. So Cook and Culver, again, this is a reference study. This is a reference study, yeah. So Cook and Culver in the year 2016, they investigated preferences for receiving skin cancer diagnosis. Remember, the word cancer is alarming in itself, right? So if there's a patient, if we're talking about a patient, the patient has gotten his or her biopsy done and is waiting for reports, what do you think the patient would prefer? Would the patient prefer being informed about their illness or otherwise through a letter, or would the patient prefer it through a telephone, or would the patient prefer a face-to-face interaction? Now we talk about, or rather say, Cook and Culver in 2016, they tried figuring out three different options over here. Now this comes without saying, all three of these different options that were given to patients, they all have their own pros and cons that we'd be discussing in a couple of minutes ahead as well. Now, taking this forward, Cook and Colver investigated preferences for skin cancer diagnosis, receiving skin care diagnosis amongst 77 patients after biopsy, right? Now, what were the options that they received? Patients could choose face to face, telephone, or a letter as the method for receiving the diagnosis. Like I said, number one, option number two, option number three. Number two, they provided with an information. These patients, they were provided with an information leaflet that explained the pros and cons of each option. So these patients were well acclimatized with what it would be like if they choose to receive information face to face, what would be the pros, what would be the cons, and they were, I mean, the pros and cons for all of these three different options were shared with the patients. Now, it's important that you keep this in mind. Number two, there was a follow up questionnaire over here as well. A month later, patients received a questionnaire with closed questions. So, a questionnaire was received that had closed questions. Questionnaires, if you talk about a questionnaire, questionnaires are an example of a self report measure. If you talk about closed questions, I think I just write it down. So, this is an example of a self report measure. And when we speak about closed questions are quicker. They help us gather quantitative data. Quantitative data helps us with comparison, so on and so forth. So Cook and Colver in 2013, they were trying to investigate what particular option would a patient, what or would a potential patient opt for after they're done with after they're done with their biopsy and they're waiting for the results of that biopsy to be revealed. So they inquired about the method of diagnosis through this questionnaire that was actually a closed questionnaire. Cook and Colver, they inquired about the method of diagnosis, whether they got the information leaflet or not, and their satisfaction at the time and in hindsight. Number one, the method of diagnosis that they had preferred. Number two, whether they had received the information leaflet. Remember, that had the pros and cons, and the level of satisfaction. There are three different factors that we'd be taking into account over here. Now, if we move on and talk about the results, if we move on and talk about the results of this specific study, it was seen that 48% of the patients or the 48% of the respondents, they chose to receive the diagnosis through a letter. So for 48%, that's almost half of them, they chose to receive the diagnosis through a letter, which again is not the first thing that would occur to many of us, because many of us would feel that, like I had said, this is certainly not the only option. The face-to-face option is certainly not the only option, but for many, they think that it is the best option. Nonetheless, it was seen through this research that around 48% of patients chose to receive information about the diagnosis through a letter. One. Number two, 37% preferred a phone call. 11% opted for a face-to-face discussion. 5% selected a combination of two methods. So again, the general impression that we hold is that face-to-face discussion would be preferred by a majority, which again is not to be found over here, right? Now, taking this ahead, some more information that we should also have. 89% of the patients, they received, or the respondents, they received the diagnosis in their chosen way. Now, again, when you're when you're talking about giving an option, that's one thing, but the ground reality was that only 89%. I know this isn't too small of a number, but then again, all 100% did not receive that information about the diagnosis in their preferred or their chosen way. There was some cases when the individuals who had actually opted for a phone call, they did not receive a phone call, and when they did not receive a phone call, they were sent a letter instead. Number two, this is again important information, satisfaction and hindsight. Now, taking this ahead, 94% of patients were content with how they received the diagnosis. In hindsight, 80% remained satisfied their original choice. However, some around 20% might not have. Only 11% wish they had chosen differently. So these were the ones who felt like they should have chosen another method. 11% of them. I'll just highlight this. Just 5% would have chosen a face-to-face discussion retrospectively. So hindsight is the term hindsight. When something is done, once it's done, once something is done and then you want to change your mind and then you think back, then you reflect back on it, and in this context you are wondering if you actually wanted what you had actually opted for. Now, if we take this ahead and talk about the possibility of age being a factor in terms of your preferences, there was no evidence suggested that age differences in the chosen diagnosis delivery method. So for this study that was conducted by Cook and Colvin in the year 2016, which again is not a key study, which again is not an example study. This is a reference study. It was seen that age was not a significant factor that made individuals opt for their preferable mean of communication, or the preferable mode of communication uh, when it came to them being communicated about their diagnosis. Now, the pros and cons for each, we just quickly brush through this. Number one, when we speak about letters, letters can be read at any time. And at times, there are some people who need some time to process that information. Letters could be an amazing example, an amazing option in that case. One. Letters, another advantage or another pro, another benefit, another strength of using letters is it avoids you from going to the hospital and taking an appointment. Number three, for the sake of convenience, those letters, they had the contact number for specialist nurses that was put there too, just in case if they wanted to receive some more of information. Now, the cons for using a letter. Number one, it takes longer to be typed and then posted. Letters would be official, and letters wouldn't really have that personal touch, that human touch in it, right? So these letters could be impersonal. Another third disadvantage of using letters is questions could not be asked straight away. I mean, there was an option of contacting the specialist nurse, but nonetheless, if you come across, God forbid, something, you would want more and more of clarity. So this was the third flaw that was noted too. Now, one, we spoke about letters. Let's take this ahead and quickly speak about the usage of telephone. Now, as we speak about telephone, this is without any doubt the quickest of method. Number two, this again avoids you to have to go to the hospital. If it's a telephone call, you could receive it at your home as well. Bear this thing in mind, the study was conducted in 2016, so we probably talking about using cellular phones as well. There are certain disadvantages of the usage of phones too. Number one, you may find it difficult to have the conversation over the phone. Now, this is a serious matter. We're talking about a possibility of being diagnosed with cancer as well. So there's a possibility that you might not be able to have that conversation over a phone call. You may be out when you receive the call. Second flaw, number three, if contact can't be made in this case, like they did, a letter was sent instead. So, number three, a face to face, the advantages of a face-to-face interaction. Now, the first one, face-to-face interactions are more personal without any doubt. Number two, you could ask any questions that might occur to you. Number three, a relative could be with you for any sort of emotional support. Now, the cons or the disadvantages of using a face-to-face, of opting for a face-to-face interaction. Number one, they'd have to go attend the hospital, they'd have to call the secretary, get an appointment, go there, wait, and while you waiting, be anxious, stay nervous, stay scared. That's all. These are a few amongst the many disadvantages that could be faced by individuals who opt for a face-to-face interaction. So we spoke about this study that was conducted by Cook and Colver in the year 2016. And what we learned from this study is that there are other options than just sticking to a face-to-face interaction when it comes to disclosing about disclosure of a diagnosis, or when it comes to this diagnosis being made. Taking this ahead, this is another study that we have very little information on this, but nonetheless, this could be used as an evidence too. So the study by Carey et al. In 2009 examined preferences of patients diagnosed with skin cancer again. Majority, that is 52%, opted for receiving diagnosis with letter over a face-to-face discussion. Again, in contrast to what the typical idea is that many people hold, that face-to-face discussion would be preferred. Now, this study again that was conducted in 2009 pretty much complements the study. Now, this was conducted in 2009. The previous one was conducted in 2016, but they both complement each other. Now, another important piece of information that we need to know about this. Specialist nurses, 25 in total, indicated that skin care centers typically stick to the traditional face-to-face approach. Now, according to some 25 specialist nurses, what a piece of information that they shared was that many skincare centers, they typically more comfortable using a face-to-face approach, or they typically do prefer a face-to-face interaction when it comes to disclosure of information regarding any diagnosis. Now, what else do we learn from this? There are certain needs for an alternative method to be identified and adopted too. Now, this study suggests a potential gap between patient preferences and current medical practices. One. Number two, this raises the question of whether alternative diagnosis delivery methods should be more widely considered as well. Now, through this study, against you see 52%, that's a majority. Even when the majority is preferring a letter, why is it that the medical system is not as yet not is not catering to the requirements as yet? So we spoke about making a diagnosis, number one. Number two, we spoke about presenting a diagnosis. I'll just take you back so that you understand it better. So, number one, we spoke about making a diagnosis. Number two, we spoke about presenting a diagnosis. Number three, we'd speak about coping with the diagnosis. Now, what does it mean when we talk about coping with diagnosis? Schofield et al., that means and others, in 2003 conducted a study to investigate how patients cope up with a diagnosis and if the presentation method affects a response. Now, we're talking about a correlation between how a patient copes with the diagnosis and the presentation method, right? So we're talking about the relationship between these two factors. We're talking about the possibility that the method that is used to disclose the piece of information to the patient, does it affect the patient's coping capability? One, taking this ahead, what is the methodology used? What Schofield et al. Did was they sent questionnaires to 131 patients that were diagnosed with skin cancer. So this is quite a decent sample. They sent questionnaires. Questionnaires are an example of a self-report measure, and all the strengths and limitations associated to them should be considered. Now, these questionnaires, they aimed to explore the link between doctor communication and patient satisfaction. Now, doctor communication and its link with patient satisfaction, the level of anxiety, the depression level. And this was conducted 4 months after the diagnosis. Once the diagnosis was done, 4 months after that, this data was collected. So yeah, diagnosis delivery methods. 32% received the diagnosis by telephone, while the rest had face-to-face communication. There was no significant difference found in satisfaction level, anxiety level, or depression levels between the phone and face-to-face diagnosis. So what we're learning from here is that the method that was used, or the presentation of diagnosis method, did not really affect the level of satisfaction. Now, this doesn't end there. There were other factors that affected the level of satisfaction and the level of anxiety or the depression levels for the patients as well. Taking this ahead, the factors that influence satisfaction. Number one, higher satisfaction was found when patients felt they were prepared for the diagnosis. Now, being prepared for the diagnosis made the or made the patients feel a bit more satisfied. So preparing for the diagnosis, being mentally prepared, again, if you're mentally prepared, then you can accept things easily. The use of the term cancer was positively correlated with satisfaction, right? So you being clearer with what is wrong, right? Number three, comprehensive information delivery, including severity and life expectancy, increased satisfaction. So what patients demanded over here was clarity. What patients demanded over here was correct piece of information. What patients demanded over here was information being delivered in a comprehensive and in a detailed manner, where they would also want to know about the extent to which their illness, about the severity of their illness and their expected life expectancy. Number four, clarity in presenting information was linked to higher satisfaction. The clearer a practitioner, the clearer a doctor is when it comes to letting the patient know as to what is wrong with them, how bad is it, how long would they probably live, and the extent to which they were prepared to know about it. Now, all these factors, these were the factors that played a more important role, and not the presentation of the diagnosis, not the way the diagnosis was presented to them. Now, there were certain factors that influence anxiety levels as well. lower anxiety for patients who are prepared for the diagnosis. Same day discussion of questions reduce anxiety. So if you have a lot of questions in your mind and you do not have someone to get answers for them from, that could result in anxiety. So same day discussion of questions reduced anxiety. Number three, matching information levels to patients need was associated with level with the lower anxiety. So catering to the patient's needs, catering to the patient's exact needs, what the patient needs to know. If you start providing information according to what the patient actually needs to know, that would eventually lead to lower levels of anxiety. Number four, meeting emotional needs through reassurance and discussing emotion decrease anxiety too. So if you catering to the emotional needs of an individual, of the patient, if you're reassuring them, if you discussing if you're discussing if you're available for them when it comes to discussion, this again led to a decreased anxiety. Next, factors that influence depression levels. Individualized information matching decreased depression levels. Like we discussed here, you match the piece of information that you're providing to the patient with that particular patient's exact needs. If we speak about patient preferences here, so evidence suggested that there were varied individual preferences for receiving a diagnosis, individual differences. Not everyone would prefer the same method. One. Number two, most patients remained content with their chosen method later on as well, the hindsight. So if a patient chose a particular method and you present information to them in that particular or through that particular method, it was usually seen that the patients remained content and they did not this particular factor did not matter. About the coping mechanisms, patients coping appeared more linked to clarity in information delivery and meeting individuals needs than the specific method that was used. Now, we spoke about a couple of references over here. Number one, I'm reading them backwards. Number one, we spoke about Scofield et al.'s research. Before that, we spoke about the study by Carey et al. Before that, we spoke about the study by Cook and Colver, 2016. Before that, we spoke about the errors that could be made by doctors. Before that, we spoke about the study by Robinson and West, and we started off with Serafino. None of these are example studies or case study. Now, having a look at what we've covered, let's focus on what is highlighted in yellow over here. So the name of the section is Patient and Practitioner Diagnosis and Style. What we've discussed is practitioner diagnosis, focusing on making a diagnosis, that is disclosure of information. We spoke about Serafino and Robinson and West over here. False positive and false negative diagnosis, type 1 and type 2 errors, presenting a diagnosis, and we also spoke about coping with the diagnosis too. So yeah, we this unit rather say this section isn't complete as yet. What you see over here highlighted in red isn't complete. Now, that is practitioner style, doctor centered, that is direct practitioner style, and patient centered, that is sharing consultation, exemplified by the following key study. The study was conducted by Savage and Armstrong in 1990. This particular key study in itself requires a separate lesson. So the relevant issues and debates, this include application to everyday life. We spoke about a couple of references that could be that could be handy and be put to use. Individual and situational explanations, cultural difference, determinism versus free will, and validity. These are the preferred, or rather say, these are some of the issues and debates that the examiners have specified. Nonetheless, you could use other issues and debates as well. So yeah, I'd like to call it a day for now. Take good care of yourselves. Stay happy, healthy, safe, and protected. Stay humble. Spread positivity. Spread smiles. Allah Hafiz.